Soft tissue repairs, probably the hardest part is mobilization and getting the tissue in the right spot. And then eventually it's outcomes. It's getting the soft tissues to heal. Rotator cuffs specifically, when you look at instability, labral repairs, we really don't have much issue with that. They heal and do well. But rotator cuffs, even in the best of case scenarios, sometimes will just fail. When a rotator cuff doesn't heal, there's usually two factors to it. One is that just the strain of it. Is the tendon under too much tension? Did we not repair it to the right place? The other is purely biological. So there's this kind of physical manner to it of getting it down and taking tension off of it. And then we have to get the biology to actually come in and heal it permanently. So retear rates are way higher than we want them to be. When we leave the operating room, we think surgery went well. That's why we did it that way. If we were to follow up with our patients, probably anywhere from 20 to 30% of them, even in good situations, probably fail. Luckily, we don't know it most of the time, but when we do, the patients definitely show symptoms of weakness and pain and decreasing function. The older you get, the more likely you are to tear. The more health problems you have, the more likely you are to tear. The poorer your bone quality, the more likely you are to tear. Nutritional status affects your ability to heal. And then there's the tear factors. How old is the tear? How long has it been there? Is the tear large or small? Is there muscle intact? Is there fat replacement? There's lots of factors that increase that risk. To me, there's two types of tears. There's traumatic and then there's atraumatic. Traumatic tears do extraordinarily well. So if someone falls off a ladder, they can't lift their arm, and we know that that day they tore their rotator cuff, we fix them, they do tremendously. People who come in with shoulder pain that kind of creeps up on them, they're the problem. They are the biologic problems. They're the ones that have tissue that doesn't have good quality, it doesn't have good healing potential, and they're the ones that re-tear. So augmentation to me revolves around, again, those factors for the patient as well as the tear. So larger, older tears, chronic tears, patients with comorbidities, they're more likely to get a graft in my hands. Right now we're working with a graft that's based out of a hyaluronic acid graft that is a solid hyaluronic acid, and it has a woven polyethylene within the graft itself. And we think that that might be the sweet spot in improving the biology of the repair.